Good morning, everyone. Today, for case is a 59 years old male patient. As cardiovascular risk factor, he presents hypertension as dyslipidemia. His cardiology history revealed hypertrophic cardiomyopathy with a septal thickness of 29 millimeters in cardiac resonance. In the past, a defibrillator was implanted in primary prevention. Laboratory tests are normal. The electrocardiogram is in sinus rhythm with ventricular rhythm, stimulated with LVVB image. The usual treatment is bisoprolol, enalapril, hardians, and atorvastatin. Currently, the patient is in functional class 2 despite medical treatment. In transthoracic echocardiogram, we can see severe hypertrophy. Gradients of the outflow tract are 45 millimeters at baseline and 94 with Valsalva, despite optimizing the pacemaker AB interval. An angiography has been performed, no coronary lesions are seen, and septal of good caliber are observed. Today's plan is to perform an alcohol septal ablation, and the procedure will be guided by echocardiography.
Thank you, Borja. So the current setup is that we have, as you can see, the patient has already a permanent pacemaker, so we don't have to do it now. And we have a radial access with a pigtail in the left ventricle and 7 French EVU guiding catheter from the femoral right artery. So this is the setup, and now Silvia can tell you some things about the imaging.
Hi, good morning, everyone. I'm the sonographer, and the guidance of the procedure, we're going to perform it with transthoracic echo. The patient is awake with us. Okay, so here you can see a 4-chamber view where we can see the hypertrophy, the septal hypertrophy. The patient has a concentric global hypertrophy, but the thickest point is the septum, the basal and mid septum. So, and this happens to be also the area that creates the dynamic obstruction of the LVOT. So you can see here, I think you can see my echo, that here is the acceleration. The acoustic window is not great, but I think it's enough to guide the procedure. I'm sorry, here. The gradient is in stimulated beats at least almost 4 meters, so it's a severe obstruction. Okay, you can also see here that there is anterior systolic movement. Here, I will show you now. We cannot see the MR very well, and it doesn't look like it's severe. But you can see here the anterior movement of the anterior mitral leaflet. Okay, so what the mates are going to, the colleagues are going to do now is inject in the septal artery. So pay attention to the septum and the consistency of it, because we're going to inject and we're going to see where this saline flash or contrast is going to go, because that's the area we're going to infarct when we inject the alcohol solution. Okay, so I think more or less these are the findings of the echo. We also have the parasternal view, which is of better quality as a backup. You can see it here. Okay.
Okay, thank you, Silvia. It's a very important thing that, as Silvia said, that we have to store all the images, because after injecting gelafundin or even alcohol, we have to differentiate the white from the black areas just to know the effect we are doing. And it's a very staring at me that as the patient has a pacemaker, you see that he has some own beats, and when the PR is optimized with the pacemaker, the gradient is lower. So you can see that the gradient probably is more or less 50 when it's paced, and more than 100 when he has his own beats. So we have crossed to the septal. We can show it. No, enseño, Silvia. We can show you the septals we have seen. The patient. Oh, no pises, cuidado. He pisado sin querer. We can see here that the patient has probably 4 septals. I don't know if This is the right one. For septals, the two first ones are quite tiny, and we are in the third one. We have access to this branch with a cyan blue wire, and we have a over-the-wire balloon 1.5 by 12. So now we are going to inflate the...
Un poquito de contraste, a ver qué altura estoy en la coronaria para no inflar.
We're injecting a bit some contrast just to know we are not occluding the LED. And I'm going to inflate to nominal pressures the balloon. Okay. Sometimes just with the inflation, you can see the gradient is going down. Now we're going to inject, ¿no?
Contrast, sacamos la guía.
Pero contrast por fuera, ¿no? Para ver que no.
Sí, para ver que está tapada.
So we are going to inject through the guiding catheter a little bit just to see that the septal is occluded and the LED is not. Okay, let's store this. Okay, we are retrieving now the wire, right? The balloon is still inflated all the time.
Hemos empezado con el balón inflado y 22, ¿vale?
Okay. And we are going to see if the septal is okay with some what's the name? Echo marker. Yeah, we are using gelafunin, a coal, and you can see the hands of Patrick working with the gelafunin. Okay, I think it's enough. I don't know if with this big syringe is going to be...
Intentar, ¿no? Despacito, yo creo que...
So we are injecting, Silvia, now gelafunin.
Okay.
And you can see the echo in the screen. Probably it's difficult because it's a very big septum.
Yeah, you can see it there.
And Silvia,
You can see that the consistency of the septum is changing.
Sí, está entrando. A ver si la ves en el eco.
Un momentito, a ver si aquí lo vemos mejor.
so we need to differentiate with the gelafunin if the area we aim to ablate is the proper one.
Cárgame de todas maneras en una jeringa más pequeña para
Sí,
inyectar un
lo
poquito
mismo,
más.
pero con más pequeñas.
Es que con esta cuesta
Yeah,
mucho.
sometimes it's difficult to
inyectado.
inject with this big syringe. We need 2 liter one. While Silvia examining this,
Well, the image is not great. with
it's not,
gelafunin,
yeah, and probably
but
the same.
I would say basal, maybe a bit of mid septum.
We're going to inject it again with a small syringe. Probably all the gelafunin is inside the balloon.
Dos dedos y lo haces de una a otra.
Is there any question from the audience?
The consistency of the septum has definitely changed. It makes a kind of acoustic
Shadow.
noise.
And probably it's the site, no? Or
Yeah.
is it the mid septum? Probably.
From the mid septum
And the
downwards.
subendocardial part of the left ventricle is also more opacified than previously.
Mm-hmm.
But the mid part seems to look not marked, the contrast.
Okay.
Probably the next septal branch.
But probably this is not a bad one.
No, it's a good place.
Mm-hmm. So we're going to inject a little bit more with a small syringe just to confirm this is the site. This is a very important key point of the procedure because if you inject alcohol without this echo guidance, and you can have terrible complications.
Silvia, are you ready?
Sorry, yeah, 1 second.
Vamos a inyectar en 5 segundos.
Okay, I'm ready.
Some colleagues do this marking with Sonoview or other echo contrasts, but the problem is that this kind of contrast retaining inside the ventricle more time than the gelafunin, and the echo is always white. And if you fail choosing firstly the good septal, you are blinded all the procedure. So I think it's a good side, no?
Good place, yes.
It looks okay to me.
Una de dos con contraste, ¿me das?
So now the next step is with contrast, with pure contrast. We are going to inject through the balloon just to check if there is any collateral from this septal to another part of the heart.
The LAD or even the LPD.
Yeah.
There are some cases of inferior myocardial infarction during ablation. Probably this is the mechanism.
Mm-hmm. I don't see any collaterals.
No collaterals.
Okay.
¿Tienes el alcohol a mano?
So if you agree, we are going to inject.
Yeah, okay.
Vamos a esperar un poco.
Sí, espera un momento, miramos hora 26.
We are missing the patient some fentanyl or how much?
Sí, por lo menos media ampolla.
Okay, because this is a little bit painful, and the thing is how much alcohol is should be administered, and probably is Sandy. How much?
Yeah.
There's a rule.
According to the thickness of the basal septum, near 25, between 25 and 30, I think at least 2.5 milliliters of alcohol is a rational approach.
It's 1 milliliter per 10 millimeters of septum, no? More or less. So, Carmen, when you administer the fentanyl, let
¿Qué
us
tal,
know.
Juan Luis? ¿Estás bien, Juan Luis?
Ahora le vamos a dar la indicación para que no le duela, ¿vale? Además me iba a notar, ¿vale? Como si fuera...
Puedes notar un poquito eso, como de opresión en el pecho, tú nos lo vas contando, ¿vale?
When the patient has no permanent pacemaker, you have to insert a temporary pacemaker just in case you see some transient blocks with the injection of alcohol. We were waiting for the effect of fentanyl. Look, the ECG and the gradient is quite interesting to see the increasing gradient without pacing. Not all the people believe in this effect of the pacing.
You can see now in live
myopathy
the effect of the early stimulation with a short PR. ¿Está al Fenta, Carmen? Vale, pues estamos en 28 minutos, ¿ok? Pues vamos a empezar a inyectar.
So we are injecting very slowly, very slowly the alcohol. The balloon is inflated all the time. All the time, the balloon is inflated. Very, very slowly. ¿Dos de golpe o uno y...?
Lo estoy inyectando muy despacito.
¿Cuál es el plan? ¿1 más 1 o
sí,
todo?
uno y vemos, ¿verdad?
Okay. So we are injecting 1 cc and then check that everything is okay.
I can see where there's
something different.
White brightness here, mainly in the subendocardial layer of the.
Only this is the radiologic contrast that we inject previously to test the septal.
Okay, that the alcohol is pushing.
¿Duele el pecho, Juan Luis? Llevo ya 1.
Esperamos un poco, ¿no? The patient is suffering a little bit of pain. We are waiting a little bit. We have injected 1 cc now. And the most important thing is to have the balloon inflated. And then when you finish the administration of alcohol, you have to maintain also 10 minutes at least inflated the balloon. After the last injection of alcohol.
I think we need at least another cc.
Let's go. We did very big septum.
Yeah, the septum is thick and it's also not a localized thickness, but it's almost all of the septum is quite thick.
Gradient is going a little bit down. Now probably is 20, no? Gradient more or less. And we started in 50.
Yeah, you can see the numbers.
And now the pacemaker is working all the time. Probably it's an effect of the alcohol. You can see there is no proper beats. Llevas 1,5.
1,5, eso es.
We have 1.5 injected of alcohol. No es más heparina. O es,
Vale.
es más heparina. You can see this is a very slow injection, very slow. We have to be patient.
2 milliliters.
Le duele, ¿no?
A lo mejor
Es normal.
podemos. ¿Qué dice? Me duele. We are injecting more or not? Just to check the watch, the time. What do you think?
Maybe we can inject here another cc, but I think it will be necessary to explore the next septal branch.
Septal.
I don't see big changes. Maybe the
Okay,
gradient
so-
has come down a bit, but in a not stimulated beats, it's still sky high.
Okay. So we have here the countdown. So from now, 10 minutes with the balloon inflated, and then we can move to the next septal.
Inyectamos aquí otro cc.
Llevamos
No,
dos.
hemos conseguido más, como llevamos 2.
Yo iría a la siguiente a lo mejor, ¿no? 2. We can check the next septal. If we are happy with the Yalafundin there, we inject in the septal. And if not, we come back and inject another more here, probably, no?
Okay.
And the effect of the ablation is always the same. During the procedure, if you succeed, you see how the gradients go down. After that, during the admission, the inflammation goes up and the gradient comes again to the original one. And probably 6 months later or so, the fibrosis is performed. And if you are successful, the gradient is definitely low.
Yeah, that's important because sometimes you expect an immediate effect, but you have to wait for the remodeling of the infarct.
The next day echo is
very bad.
It's very bad usually, but
Echocardiography
3 to 6 months.
It's really on the cusp, right?
Any question from the audience?
Yes, we have one question. Are there any specific consideration for navigating the catheter in the septal branch?
No, not especially. No, it's a coaxial. It's a coaxial balloon, 1.5, and the navigation is not usually complex circumstances. Sometimes it's difficult to cannulate to selective wire the septal, but usually performing a more prominent J-curve, it's relatively easy to enter the septal and then the coaxial balloon.
Yeah, today Santi crossed the septal in, I don't know, 10 seconds, but the other day we are struggling for 20 minutes to engage the correct septal. But after you have the septal, the balloon goes almost always because they are usually normal coronary arteries. And the other thing of the balloon is that you have to choose a balloon 1-to-1 to the size of the septal, just to occlude it properly. So in this case, we have chosen a 1.5.
Another practical issue is that we use a coaxial balloon, so we need a longer wire, or even perform like we do previously a trapping of the wire to advance the coaxial balloon.
Yeah, it's quite, for me, it's more uncomfortable to work with a 300 wire in length because it's quite uncomfortable. So having the experience of the CTOs and complex and rotablator and all these things, we prefer to do trapping. But you need a specific device or 7 friends. This is true. Any other questions?
Yeah. Any consideration for the administration of the alcohol?
No, as Alfonso said during the case, very slow injection with monitoring of the ECG to see there is some type of conduction abnormalities. But this patient is already on pacemaker rhythm, so we don't have this problem. And the anticipated amount of contrast of alcohol, is the rule that Alfonso said about 1 cc per 10 millimeters of septal thickness.
Okay. For the echo team, are there any specific criteria you use during the echocardiography guide procedure to ensure optical outcomes?
Well, I think in this procedure, the main objective of echocardiographic survey guidance is to ensure safety. So the main thing is not to inject alcohol in a septal that irrigates the structure that we don't want to infarct. For example, a papillary muscle or part of the right ventricle. So that's the main point. Then, as we said, sometimes the effectiveness of the procedure can so, well, depending on the septal anatomy, you can inject if you think it's safe to do it. And well, expect the best result. But I would say the main point of the guidance, of the echo guidance, is to ensure safety in this scenario.
Okay.
Any other question, Borja? Or not?
No.
Okay, we are waiting. We have to wait just 3 more minutes. A very interesting point. We are seeing the ECG, and now you can see there are not proper beats, but sometimes they are stimulated only in the ventricle, and other times in the atria and in the ventricles. So we are doing something there with the alcohol that is changing the stimulation and also the gradient. So we are going to retrieve, after these 3 more minutes, we are going to retrieve aspirating the balloon just in case there is some alcohol inside the catheter, and then let the guiding catheter breathe, and again advance with the wire to the next septal.
Déjame una jeringa de 2 con suero, porfa, con gel para seguir aspirando. Para cuando lo saquemos.
Y marcamos el alcohol bien. And another important thing is to mark the syringe with the alcohol and differentiate perfectly from the other syringes. And when do you, Santi, consider the procedure successful?
The perfect result is zero gradient, but at least we should our objective should be at least 50% reduction on the basal gradient.
Mm-hmm.
Usually, when you find the accurate septal branch, the effect is very marked, is very clear, and you see a drastic reduction in the gradient.
But probably in this patient that has 3 or 4 big septals, we can see also compression of the septal in the myocardium. Probably we need to treat more than one. In patients with only 1 big septal, the effect is like Santi told us.
Yeah, you can see in the second of the big septal branches, that is a trifurcated branch. The bigger of the branches have a clear phenomenon of milking or systolic compression due to be inside the hypertrophic myocardium. So probably this septal will be more accurate than the previous one, maybe.
Borja, another question or not?
No.
Yeah, the thing is also you can see here in the echo that the extension of the area of obstruction is very long, like from the mid-ventricular the mid-ventricular area to the basal segments. So it's a big area in terms of longitudinal extension.
No, it's a challenging case because it's a very big septum. The gradient, as Silvia said, is not in a certain point. So yeah, it's a case for mainstream.
Well, we have wait 10 minutes after the last injection of alcohol. So we deflate.
We deflate the balloon, and we are aspirating
we
with
are
negative
going
pressures.
to retrieve the balloon because we will use another time this balloon and not to inject and not to lose the alcohol remaining in the LAD.
Back bleeding here, and you are sure everything is out. Okay. So let's go with the wire again.
Lo lavamos bien esto también, Patri.
Sí.
Con suero y...
Mira, a ver la J si está modifica un poco.
Yo creo que es bastante parecido al ángulo al anterior, ¿no?
Que se te haya modificado, digo. A ver si te... This one, I don't know if it's a little bit more difficult to engage because it's like bifurcated from the origin, no? Or... And I think we have to go to the first one.
¿Dejas el rotor, Patrick?
The torque.
O sea, ya.
The guided catheter is not helping us so much. There you are. Perfect. Cranial view. Probably, no?
No, this is the next one.
It's the next one, yeah.
Yeah, there.
I think you are in the distal part of the bifurcation. You are there, I think.
¿Tiene?
Okay.
Maybe this branch, no?
Yes, you are in the correct one, I think. So let us advance the trapping balloon and then the... Oh, careful.
Intentar ir un poquitín más distal. Bueno, por ahí va. El trapping, porfa.
We are using a workhorse wire, but sometimes you need a polymetric one if there are more difficulties in advancing.
¿Me echas una manita aquí a la guía, Alfonso, por favor?
So we are doing the trapping balloon technique, advancing a 2.5 balloon in a 7 French guiding catheter.
Okay.
Cuidado que estás en el tronco, retira un poco el balón.
Sí, es muy largo.
Up to 18, more or less. Check that the wire is strapped. And let's go with the balloon. You can also advance together the balloon and the wire, but now as we have the trapping balloon here, and Patty was washing the balloon very well, we have done like that. And now the wire is advancing a little bit. Yeah, I have the wire.
Okay.
No, okay, strapped. So deflate the trapping. We can retrieve it. It's open the...
Yes.
Okay. Okay. Trapping is yours. Okay. So
you can see the 1.5 balloon entering the septal.
the marker is in the middle of the balloon, so you can probably you are there. No?
Yeah, maybe
A little bit further.
If we inflate back proximal, we can occlude the two branches.
Probably.
Maybe we can try. The problem is that if we are very near the LAD, when we retrieve the wire, the balloon can go up.
Mm-hmm.
But so I think we are going to inflate here.
A second, another test, please, just to.
Yep.
I think we are there. Okay, I'm going to store this. I'm going to inflate the balloon. Okay. The nominal pressure, that is 8. 8, okay.
Tiene a ver si estamos to see if we are occluding the two branches. No, the second,
just the
second is
proximal,
opened,
but LED is okay, and this
more,
branch is good.
more selective injection in the target branch.
And the other thing is, look, the first septal we treated. It's different now. It's like TME1 or 0.5.
Puedo sacar la guía.
Okay, we're retrieving the wire.
Espera que no sale. A ver, despacito.
Un poco atrapada.
Está un poco atrapada, sí. Vale. Pues los mismos pasos para
Okay, we are repeating the same steps with the gel funding.
Ese es alcohol, vale. A ver si ahora opacificamos la parte más medio ventricular.
Probably the white part you can see in the echo is the alcohol, because the gelafunin is washing.
Voy a
inyectar gelafundina, ¿vale, Silvia? ¿Estás?
Okay.
Voy.
We're injecting the amount of gelafunin you need is similar than the alcohol. Probably with 1 cc or so,
It seems it goes to the mid-ventricular.
septum. Yeah.
Okay.
And it's not going anywhere, no? Anywhere else, I mean.
No, nowhere else. The papillary muscles are fine. The apex is fine.
Free wall.
I don't really see the right ventricular free wall,
but
it's
window.
okay.
Okay,
Here.
but the septum looks a good place.
Yeah.
You agree?
It's a bit more apical than the previous injection.
So if we agree, let's go with the alcohol.
Un poquito de alcohol.
The contrast. Yeah, this step is important. Administer contrast through the balloon, inflated balloon, to check there is no collateral to other parts with the angio. No collaterals. Okay. If you do this step before the left funding, probably you opacified everything in the echo and you can't see anything.
Alcohol, Patrick.
Like now, for example.
Gracias. Voy a empezar con el alcohol, ¿vale?
We are injecting very slowly. 1 cc more of alcohol here in this branch. Very, very slowly. And remember, just start your chronometer at the last injection, not on the initial one of alcohol, to maintain 10 minutes more the balloon inflated. No, puesto más, ponle más fenta.
Juan Luis, ¿cómo vas? Dolor en el pecho, ¿no?
We're administering fentanyl before every injection of alcohol.
Un cc tenemos ya.
And this is not the usual case of alcohol septal ablation. We usually inject less alcohol than now, but this case is quite special because of the thickness of the septum.
Look, you can see here how the mid septum has become hypokinetic. Here.
And the other consideration in this patient is that if surgery is a better option than alcohol septal ablation or pacing, no? But surgery implies a higher risk in a young patient as well, and this is always an option. If this procedure is not successful, you have this option as well. But if you have the surgery, probably it's not the same. ¿Qué hacemos? ¿Uno más o...?
Ya llevo 1,5.
Pues hasta 2
O sea,
ya, okay.
sí.
We're injecting 0.5 more and probably stop. And then we start with the chronometer, 10 minutes more.
The balloon is in place. Vamos a lavar un poquito el catetería.
Any questions, Borja, from the audience? So as you can see, it's not the most difficult procedure we do here, but you have to be very precise with patients step by step, because if not, you can have a complication.
¿Y sigue teniendo aceleración desde muy distal, desde el apex, o es más basal? ¿O si conviene volver a la anterior rama, o que por la anatomía parece que tiene aceleración desde el apex, ¿no?
So the acceleration is like from the mid segment, and the highest velocity is basal. Here, mid basal. Yeah.
Now let's see the other projections if we have another septal. Another controversial issue is that in some cases, some groups are doing only one septal per procedure, and let the patient come back again just to be sure to not have any complication, and do these procedures in different procedures. But as I told you, this is a special one because of the thickness of the septum. What do you think? While we wait,
I think that unfortunately the gradient response is not as expected. It's only 10
The highest
to
gradient is basal.
15
We have one question.
reduction. And I think that sorry.
Any contraindication for a cold septal ablation?
Well, contraindications, the main probably is that the septal anatomy is not appropriate for this case. The ideal case would be a very proximal big septal branch, the only one to ablate. But in this case, you can see there are at least four branches that would be treatable. And when the septal thickness is not below 50 millimeters, is only relative contraindication to inject.
Yeah, very, very small septums below 15. That also the diagnosis of hypertrophic cardiomyopathy is controversial.
Yep.
And even larger than 30, and we have 20 something in this case.
Yep.
They are relative contraindications, and the main thing is the anatomy of the septals, I think. And to check everyone with Jalafunin or Sonoview or whatever, just to check you are not doing any complication. You can succeed, but you have no complications, and that's all.
I think if we have time, we should test the first septal. Is the smaller, but I think that sometimes it's not a matter of amount of contrast. The main factor is the place. Is that the accurate precision to ablate the more basal, the more superficial endocardium of the near the contact of the systolic anterior movement of the anterior mitral leaflet.
And you mean the first one or the first we treated?
No, the first thing that we entered, the one that is before the first the septal.
The first one is tiny.
There is another.
There's a curved one, a very tiny. The second one is
very complex because it's too proximal and very angulated. But I think that the entry in the second septal is easier, and I think that
this one
would be at least 1 cc we can test.
if we
in
do
this
that.
position.
I think we will have time. The problem is with this balloon probably the guide wire is going to be stuck because we have had some problems in retrieving the wire.
And we can use another balloon.
And indeed this branch is smaller, so probably we can use the 1.2 balloon.
1.2, okay.
I don't remember the time we have to deflate the balloon.
Okay, I think 2 minutes more.
2 minutes more.
Yeah, in the echo, you can see that we have almost reached the apical septum, almost. So I would definitely not go any farther to the fourth septal.
For sure, this is a special case. We usually focus on the very basal septum, but now in this mid-ventricular gradient, very big septum, we have changed the usual.
You see,
this is the problem. You cannot choose what the anatomy. The anatomy is a uncontrolled factor.
Yeah, and sometimes we undergo with the coronary angiography at the same procedure, but for this case, we have done a coronary angio before just to check the patient has some septals to ablate.
Okay, let's deflate.
We are doing negative pressure, and Santi is retrieving the balloon. And we can throw out this balloon. Back bleeding, perfect. Lo puedes eliminar.
Un test para ver, to test the LAD flow.
Some water in the. Okay.
Tiene.
Yeah, we can see ablated all the septals.
The two septals that we have treated are occluded. Let's try the first.
Yeah,
okay?
Let's go. We can go with the balloon and the wire inside the balloon at the same time because we avoid the trapping.
Sometime. Déjame el balón coaxial, porfa. Y la guía otra vez.
Lo montamos. No, pero dentro del balón ya. O sea, abre el balón.
No, podemos meter el balón directamente y luego la guía, ¿no?
Por eso, sí. Vamos. ¿Es este? No, el de 1.2. El nuevo. Carmen, 1.2. El balón de 1.2. Vale. 1.2. Espera, aquí es J la guía. Al de J la guía. Que al de J la guía primero.
¿Es nueva la guía?
Ah, bueno, es verdad, es la misma.
Es la misma, ¿no?
It's the same wire. El balón está ahí, ¿eh?
Sí. Vamos a ver. Usa la spider para entrar.
So probably if you're doing this procedure in your labs, it's not a good idea to do 3 or 4 septals in the first day. There you are. Okay, so la diagonal.
Esta diagonal.
Is this one, no? You can do a cine when you are there.
It's okay?
Yeah, I think so.
I think.
Because there is no flow now in the septal, probably because it's so tiny.
Mhm.
Yeah,
It's
this
branch.
branch. Okay, perfect.
Tengo que poner un poquito el catéter y avanzar un pelín más si puedo.
Okay, you're almost there. Going to check a
Pequeño
little
test.
bit. You are there.
Vale.
Okay. Let's store this.
El balón,
The
por
balón
favor,
va a inflar.
el manómetro.
Manómetro. Este balón ya no queremos estar dentro.
Inflator, sí. Yo te conecto.
So the same steps. We're going to inflate. Nominal pressure is the same, 8. Okay. I'm going to inject through the guiding. Septal is occluded. The LED is okay. Okay. Let's store this. Okay. We retrieve the wire, and then we will repeat the thing with the gelafunding.
I don't know if I'm going to see anything this time.
Yeah.
Because I have the shadow, the acoustic shadow
true.
from the
Alcohol.
top ablated myocardium.
Let's see the gradient.
No, the main thing is not to see any white thing outside in the apex
Outside.
or
Yeah.
we're injecting, Silvia.
Okay.
What do you think?
I don't see anything wrong, I mean.
The gradient is slowly decreasing.
Mm-hmm.
I think only with the inflated balloon, maybe we have reduced another 10 millimeters.
Mm-hmm.
It's not a bad thing.
We began with 50
Now we have a gradient of 30.
Mm-hmm.
The vessel was 50. Oh, I think 1cc is not a problem to inject.
In the echo, I don't see any white image outside the septum, no? So
No.
we
I
can
don't
go
see
with
anything.
contrast,
Yeah.
just to check is there any in a small syringe, any collateral flow. And if not, we can go with 1cc.
It's a very small septal, but
Small septal. Sometimes the smallest are the good ones.
with the best place.
There is no
Okay.
collateral there. The balloon is
Should be
inflated.
nice.
So the alcohol is this one.
And the gradient has come down.
Yeah. We are going with 1cc very slowly.
Estamos en 31.
Mm-hmm.
Okay.
Ya cuando acabes lo miro. Probably a good rule is to use 1 minute per cc of alcohol you administer, more or less. Silvia is doing her magic with the echo and these sepia things. And
No. I hit the wrong button.
jellyfish mode.
No room
Vamos a
for
poner
freely
otra vez,
in
por
this
favor.
case today.
¿Te duele ahora más que antes, Juan Luis? Parecido.
Parecido.
Important to repeat the doses of fentanyl or whatever you use for relieve the pain.
There is also a less pronounced systolic anterior movement.
Mm-hmm.
We're doing something. I know if only the settle of the whole thing we have done, but for sure the gradient has decreased.
Yeah, it's looking good, this last one.
It's not 0, but
yeah. But the ventricular pressure has also decreased. Maybe some stunning is correct.
Stunning, yeah. I think we are not injecting more.
No,
probably.
no more. No
So
more.
32 there in this watch.
Mhm.
10 minutes more. I don't know if we'll have more time because it's 1 o'clock. We need 10 minutes or 15 to complete the case.
We have injected near 5 cc's. Is
enough.
Large.
We will give you a few more minutes.
amount
Yes.
of-
2 more minutes. Okay.
Okay.
This is an interesting case because this last one, I think, is clearly the one that decreased the gradient.
Yeah.
But
This is the smallest one.
I'm not sure if it would have been as effective without the previous ablation of the more apical septals.
Probably.
Like the mid septum is now hypokinetic, and clearly the acceleration at the mid level has decreased with the 2 first injections.
Mhm.
So
It's the whole work.
I think this was the last drop.
Maybe we have to learn that the first should not be always the bigger, no, but probably the more proximal.
The most important thing is to look the echo. No, if you are in the point you want to ablate, you can try.
Yes.
Quedan 10 minutos. So we will have to disconnect in a couple of minutes, and we will finish the case in 10 because we have to maintain the balloon inflated. Is there any other question, Borja?
The gradient has decreased to 0.5%. No,
Yeah,
to
more than half because we started with 50 millimeters of mercury of basal gradient. Now we have
25.
25, yeah, more or less. And
Probably this is a septum with a very large network
yeah.
of septal branches, and it's difficult to induce a large necrosis area. But I think that small necrosis, maybe that in the follow-up we can obtain a good result.
Successful result, yeah.
Yeah, it's a big area. I think we need to wait for remodeling.
We have one question.
Mhm.
What anatomical or physiological factor challenge you face during this procedure?
This procedure, this specific.
Sorry,
Yes.
What factors of this procedure, anatomical or functional, was challenging in this procedure for you?
In this procedure, I think that the two things, especially the hypertrophy was basal and mid-ventricular, and the septal anatomy with 4 or 5 branches, that is difficult to target all of them. I think that are the two main difficulties of this case.
It's a very complex case for this type of procedures, I think. We're waiting 5 minutes more or so.
Theoretically, 32. We have
32 was the beginning.
We have 4 minutes.
So just to recap, just in case you cut us the connection, alcohol septal ablation in a very big septum 27 or 26, successfully reduced gradient more than 50% with no immediate complication. Different septal branches, starting with the one we see in the echo is the good one with gelaflunin or Sonoview or the contrast you use, and trying to avoid any complications is the most important thing in this procedure. I have to wait 5 minutes more with the inflated balloon. If you have any other questions before we finish the connection, we are happy to answer if we know the solution. How is the follow-up with the echo, Silvia? In 1 month and 6 months, or?
Well, we always do a check before discharge, obviously, more than anything to rule out complications. And then, yeah, I would say follow up 3 to 6 months. Yeah. To see the gradient has effectively decreased.
But it's very important to remember that the echo in this chart is going to have the same gradient or more than a beginning,
exactly.
and even if you're successful. So sometimes
it's not representative for the final result of the procedure. Yeah, totally agree. Also, we need to warn the patient, of course, that the improvement is not going to be immediate, straightforward. Yeah. But I don't see any complications. I mean, it looks good to me. Systolic anterior movement has also improved, I think.
there was no MR at the beginning, so it's difficult
There
to.
was a bit of MR, but the acoustic window in this position is not the best.
Yeah.
So maybe we can assess it tomorrow, or well, in a couple of days.
And the patient is going to be following the coronary unit, just in case there's any complication. You are producing a myocardial infarction. And it's interesting to have biomarkers the next hours, and even if you don't have a permanent pacemaker, to restart with the beta blockers that we stopped yesterday, the day before yesterday, because if you have any block, you can see when the patient is in the CCU. And now with the permanent pacemaker,
Well,
that not makes
this
sense.
case is easier in that sense, yeah.
And probably after 24 hours or 28, the patient can go to hospitalization.
Well, it's an infarct at the end of the day.
Yeah.
So
3 minutes more.
In the future, in 6 months, we can
show the echo, no?
We can show the echo.
In the case of the measuring case, following 6 months. Two minutes more.
1 minute, maybe.
1 minute, 1 minute, okay. 1 minute. A small balloon, a small quantity of alcohol in this case.
Caballero.
Borja, do you have any question by yourself or not? No. Borja knows everything about this procedure.
estamos acabando.
The balloon is in place.
I don't think we're going to see many changes at this point.
Okay.
But echo is the same. Okay.
Angio, por favor. Escopia, digo. Ah, no. Visto no, que había visto el balón, una imagen que parece que el balón se había ido más abajo.
Está un pelín más distal, pero sí.
Look the gradient. Is the lower we have had during the procedure, probably the lowest.
About 20. No?
Okay, I think we can deflate the balloon. This is alcohol. Dame una jeringa para aspirar. We are deflating the balloon. We are doing
Cesto negativa.
negative pressure, and Santi is retrieving the balloon, back bleeding in the guiding catheter, and we are going to do a final angio to finish the case.
Perdona, Silvia.
No, perdón.
Que vamos a hacer una
y acabamos.
no te radies el brazo, ¿vale?
Probably is water in the. I can repeat.
Okay.
Okay, we have updated all the septals. LED is okay. And the gradient is very much lower, so we can.
Angiographic result optimal. Total ablation.
Optimal. Also echo. So thank you. We can disconnect now and see you in the next case in some minutes.
Thank you.
Thank you.